Hi, Scott Shannon here. Today we're going to be talking about MDMA and its clinical application. So we're going to be talking a little bit about the actual function, what MDMA does clinically. We're going to be talking about its history, its background, a little bit about the effect that it has, how to work with it. We'll be looking at the protocol that MAPS has used in phase 2 and phase 3. We were lucky enough to be a phase 2 and phase 3 site, with me working as the principal investigator on those trials. And it's really very different work. It's very important work, and it's not the same as the classic psychedelics, and it's really not the same as ketamine. So it's a specific case unto itself. It's really worth looking at in more depth. And I think it's really a landmark and a pivot point in the history of mental health, that we're actually going to be looking at a medication that is used to accelerate psychotherapy as opposed to just merely mute symptoms. So a pivotal point in history. I think MDMA is a critical stepping stone, a major landmark in this new paradigm. So let's jump in and explore a little bit about MDMA more specifically. So some disclosures: I've published 4 books or textbooks on integrative mental health, and I've been a PI on a number of different studies, and I'm on the advisory board of Maya Health, a public benefit corporation. Today, we're going to be talking about MDMA. It's been around for a while, over 100 years. It was originally developed as a styptic agent, that is, to prevent bleeding following shaving. And it really didn't work very well for that. So it was dropped and paid no attention to until the 1950s, when it was explored as an agent for weight loss. And it really doesn't work very well for that, because the effects of MDMA fade when it's taken repetitively over a number of days. And then it was probably in the 1970s that we began to understand that it could be used psychotherapeutically. It's now considered to be an empathogen. So it's not a classic psychedelic, and there's very little perceptual distortion or loss of control. In fact, I've had people tell me on MDMA that they've never felt more in control and more themselves than they are under the influence of MDMA. There's this open-hearted sense, this sense of being close to others. I think the oxytocin is responsible for some of that. There's a profound sense of safety and well-being, a sense of empathy for others, and a real ability to have insight and to understand your own history and where you're at this very moment. So one of the reasons that this is such a big advance forward is we're sort of coming to the point where we realize the grave limitations of both psychotherapy and psychopharmacology. And so those of you that are psychotherapists know that psychotherapy really has some limits and challenges. And I've got a list of things here, such as I've tried that and it didn't work. It's not strong enough. We're just talking. And I sometimes reflect the challenges of working with my own gender, which is you just can't get them in. And getting men into therapy is difficult, particularly I'm a child adolescent psychiatrist. Try getting a 12 or 14-year-old boy in for talk therapy. It is like pulling teeth. And then I think there's a sense of how do you know who's good? Which model is best? You know, when I trained, there were 700 different forms of psychotherapy. I think what I've heard lately is the number is closer to 3,000. And how do we know which one is good? CBT has the most evidence, but what does this mean about all the others? You can't really find very few people in a metropolitan community who just do CBT. I mean, it's sort of painful. It's kind of boring. It's it's difficult to find people who that's all they do. And then I think we have the other challenge is that people are just defensive. They're armored. They have trauma. You just can't get through to them, and it makes it very difficult to have progress. And then finally, how do we know when we're done? I feel better. Am I done? Is that it? And so psychotherapy, I think it's what we're seeing is that it's useful in general. It has a positive sense. The non-specific factors, that is relationship, connection, rapport, trust, etc., seem to probably be more important than the actual type of psychotherapy that's done. But what we know now is clearly that when people are very seriously ill, psychotherapy is slowed imperfect, incomplete, and I think frustrating. And we can go on and look at psychopharmacology, those of you that are prescribers. We now often see that, for example, as many as 30, 40, sometimes even more percent of depressed patients become, quote, treatment resistant, as opposed to weak therapy. And, you know, we sort of put this on the patient that they're resistant to improvement, when really we have very imperfect treatments in psychopharmacology. And if you, those of you that do a lot of med checks know that they can be sterile, unrewarding, and just unsatisfying. People coming in for this endless cycle of revolving door med checks. I don't want to become dependent on meds. We now have 10 to 15 million people in the US that are on antidepressants that would like to get off and have trouble with that. The side effects can be profound. For example, with Risperdal, Zyprexa, olanzapine, that people will gain 10 to 20 to 30 pounds in the first few months. And, you know, I think as we look at these two arms of the mental health paradigm, psychotherapy, psychopharmacology, the psychopharmacology often makes people less able to do the psychotherapy. And then finally, and perhaps most importantly, is that the scientific premise and foundation of psychopharmacology in the modern era, that is based on an imbalance of neurotransmitters, really doesn't hold true anymore. No reasonable neuroscientist holds a chemical imbalance model of depression at this time, serotonergic model of depression. It's just more complicated than that. We're now moving to networks and hubs in the brain. The biochemistry of the brain is just seen as too vague and nonspecific to really give us much specificity in outcomes or treatment effects. But what if we could combine these two things? What if we could take the positives of psychotherapy and the power of psychopharmacology and use it together in a positive synergistic way? Well, what we'd do is we'd have some of the things listed here: enhanced engagement, more excitement. People would be able to access their trauma. We'd have increased awareness of the conflicts and challenges they face. There'd be increased motivation to engage and make changes, less defensiveness, avoidance, fear, and the brain would become more neuroplastic, more able to open up to change. So that's this ideal new world, and that's the new paradigm that I think we're working towards in the psychedelic paradigm, which broadly embraces ketamine used with assisted psychotherapy, MDMA assisted psychotherapy, and then the classic psychedelics like psilocybin and LSD. So really with MDMA, we're looking at a new medicine for an old model. I mean, William James toyed around with nitrous oxide in the late 1890s. And here's a publication from the British Medical Journal in 1944 talking about narcoanalysis with nitrous oxide. And they talked about, in this article, they talk about the drawbacks of working with benzodiazepine, or excuse me, phenobarbital, the barbiturate groups, and maybe the benefits of working with nitrous oxide. Interestingly enough, nitrous oxide, laughing gas from the dentist's office, is now under investigation as a treatment for depression. So things come around again, and our work with MDMA using this sort of broader psychedelic framework is something that we've known for a while, but we now have agents that I think are really quite effective. So let's talk about that psychedelic paradigm. And this is the framework that we're using with ketamine, we're using with MDMA, but also with holotropic breath work, with 5-methoxy-DMT. And it's been around for a long time. It may be some variation on the shamanistic framework that has been known since prehistory, but we have now this modern psychedelic paradigm, which is really three main components. First, we have the container, which is the therapeutic container that's built through relationship, a sense of safety, the setting, trust. And this is, I think, the foundation of it. I think without this, we just have psychedelic agents, and people could be at a rave or a music festival, and it's not a psychotherapeutic intervention. The second thing we need is a catalyst that actually changes consciousness, that alters the flow of information, that shifts perspective, that gives us access to different places within our psyche and consciousness. And we call these agents, and today we're going to be talking about MDMA as a specific agent. But as we move from agent to agent to agent, the psychedelic paradigm remains roughly the same. That is, container, catalyst, and the last component is the carrier. This is the use of music, the use of eye shades, the use of drumming, other things that help to free up awareness, free up attention so that it can move where it needs to move. Because without music, without eye shades, it tends to be a more external focus, and people tend to get stuck in the process, and they tend to get stuck around sensations and input, and it's not as much as an inner journey. So the psychedelic paradigm is container, catalyst, and carrier. Those three things together are what we're going to be talking about today. So in psychedelic-assisted psychotherapy, within this psychedelic paradigm, what we have is a synergy between the hardware and the software. And as I mentioned, all these agents use the same clinical frame, but each individual agent has its strengths and weaknesses. For example, for trauma, I definitely want to use MDMA, but for severe entrenched depression, psilocybin may be a better invention and choice. And what we'll see is that each medicine has strengths, weaknesses, time course, time frame, risks. Each one is very individualized. So although they all fall under this psychedelic-assisted psychotherapy umbrella, call it the psychedelic paradigm, they have very individual pictures. Also, each person has an individual picture. So each person may be more or less sensitive, may respond to one and not the other. And so I think as we mature from the sort of infantile psychedelic model that we're in right now to a more mature model, maybe 10 years from now, where we have a palette of options that we can choose from: psilocybin, LSD, 5-methoxy-DMT, ketamine, MDMA. We have this broad choice. Then how do we triage people? And I think we need to do it in a way that's thoughtful, biologically based, and scientific. We're not there yet, but that I think is a goal. And so what you can see with these agents, they're all so different. MDMA to ketamine to 5-methoxy-DMT, they share no similar mechanism. There's nothing similar about these chemical compounds. What they share is their ability to alter consciousness and the flow of our inner experience. And so I think as we understand all that, we can understand the challenges, the strengths, the process of this model that we're working in right now. And that's really what we're here to talk about today. So we've got a number of trials that are in process. MDMA, the one that I've been involved in, it's been completed as of a year ago. We've wrapped up all the associated after studies, the crossover studies, and MAPS is about to submit the IND mid-December. And as of taping this, it's likely to be imminent. We don't know exactly when. Perhaps by the time you hear this, it will have already been submitted to the FDA. The FDA then has a month or two to ask questions and explore with MAPS some of the details of it. And then once the application is finalized, they have 6 months to give a response. We're hoping August of 2024 for new drug approval, knock on wood. And we can then begin to think about commercialization, rollout, and some other things that would be useful for us to talk about. So we also have psilocybin in 2 different processes. It's in the midst of phase 3 with Compass, which is a for-profit company out of Europe. And phase 2 was just completed by USONA, a nonprofit company out of Madison, Wisconsin. They're about to begin their phase 3 study. So if things go very well, Compass is probably ahead by 6 months or a year or more. Compass could complete their phase 3 study middle to late next year. And then we could have approval for psilocybin in a medicalized process by 2025. You should know and recognize that it's already been approved on a decrim model in Oregon and now in Colorado. And we're using it in our office under the personal use criteria and a harm reduction model. So psilocybin is coming. I think we're going to see the same process that we saw with the rollout of cannabis, sort of state by state, and it'll gather steam and build momentum over the next probably 5 to 10 years. I can't really say about how this is going to look in Canada, but I think we can see that the trend and the process and the momentum is building in other countries as well. So with that, we'll end this first segment, and I hope that was helpful, and really look forward to helping you move through the next pieces of this understanding of MDMA as a clinical tool. Thank you much.